This was a study that was done, and I'd like to pay tribute to my colleague, um, Louise Cadman, who actually ran this study and did everything, and sadly developed a melanoma of the skull a couple of years ago and died just last year as part of the study. So this is very much her study, and I'm delighted to be able to report it on her behalf, but sorry that she can't do it herself. These are the standard disclosures. Basically, it's just samples from people that companies that were providing information on this. The basic study was um, was was basically I'm jumping around here. We went to a clinic, the Royal London Hospital, that was a colposcopy clinic for women with abnormal cytology. 620 women were invited to join. 20 got excluded for minimal reasons. So there were really 600 women in this study, of which all provided pairs of vaginal samples, plus 505 also gave a urine sample. So the randomization, everyone was asked to give a urine sample first, and then they were randomized in one of four groups. They either were asked to look at the Copan's flock swab and the Digene test. We could only get 2 tests per woman realistically, or the Her swab and the Quintip test, and the order was randomized as to which one they did first. So there were 150 in each of these groups, and as I said, most of them had a urine sample as well. This is now published, as I said, in CEPB. Louise Cadman is the first author. It's very much her work. The devices, of course, they look really quite different. The Digene wet swab is just transported in a tube and is well known. The flock swab is Copan's. It's transported dry, which has a lot of advantages for self-selection because these are much easier to send through the post. Then there was also the Her swab, which was a more complicated device. The hope was that women might find it more user-friendly, but in fact, the opposite turned out to be true. And then the Quintip was another essentially brush-type swab. And then we also use the Novosantis Colli-P for urine. It's a very nice system in which it allows you to collect the first pass urine. And when it gets to what we set, we had the 220 ml samples. When it got to 220 ml, the rest of the urine just immediately went onto a funnel into the toilet. So it was a very, very well-received, simple device. So here are some of the simple results on that. There was really no impact of sample order. We got positivity rates virtually identical in the first and second sample from both of these. There's nothing significant there. And we use for this first analysis, we're doing additional analyses with the new QIAGEN's, their PCR test, but this is all based on the OnClarity Becton Dickinson BD test. And we initially looked at their recommended cutoff of a CT score less than 34.2. And when we did that, we found pretty similar positivities overall certainly between the Digene wet sample and the flock swab, both at about 70% positive. The Quintrip dropped somewhat, not significantly different, down to 65%, and the Her swab down to 61%, which was significantly lower. Urine was high. It was as high as anything else. And I'll show you why in a minute. But basically, you can see that there are 3 tests: the Digene, the flock swab, and the urine, all giving good positivity rates, and that was reflected in particularly good positivity in CIN2 pluses, lower than you would get from a clinician sample, and we've looked at that by raising the CT cutoff levels. Again, urine, although as positive, was not as positive for CIN2 plus. It wasn't as specific as the other devices. The discrepancies here, as I said, there are very few discrepancies between the wet Dacron and the dry flock swab. Only 13 positive for Dacron versus wet Digene and and 12 for the dry flock swab. Good agreement, 92%. Less agreement between the same woman taking either the Quintip or the Her swab sample. And again, less agreement with urine, although still not too bad for the two main types, the wet Dacron and the flock swab, producing about an 85% agreement level. And no real differences for one being more favored from the other. But you can see when you look at urine or the Quintip Her swab, very often it was the urine that was positive and the vaginal sample that was negative. So there was a clear difference in the direction in which the disagreement took place. Some of this is sort of reflected by the amount of cells. We used a beta globin sample to look at the cellularity of the sample. And the most striking thing is that Her swab had a huge variability in the amount of cells that were actually collected. And I think is one of its real problems is that it's, again, high levels here are high CT values, so it's low cellularity. That was particularly apparent in Her swab. Urine gave good samples. There was typically more material there, although we collected a bigger sample. It was 20 ml of urine versus 10 ml in the swab. So urine gave more cells. The digene, fewer cells, but the positivity was very good. So anyway, the main fact there was that Her swab was highly variable. And to get decent answers with Her swab, we actually had to adjust for cellularity. When we did that, the things were somewhat more similar. We got essentially, just focus on the CIN2, the rates for CIN2 plus 86% positivity is sensitivity with the digene, about 80% for the flock swab, and lower for the Quintip. The Quintip did pretty well, and the thing that really improved was the Her swab because the cellularity was so varied. When we actually adjusted for cellularity, we got sensitivities for SYN2, which were similar to the digene wet Dacron, and positivity rates, which were pretty high as well. So one of the things that concerned us was that the positivity rate and sensitivities were lower than for typical clinician samples. So we actually raised the cutoff to 38.3 for CIN for HPV 16, and with that, the sensitivity improved dramatically up to around 90% for the two main types, 87% for urine. So the first kind of conclusion was that probably we needed to use a higher cutoff than was initially recommended by the company, and they've accepted that now too, that to get the sensitivity to be adequate, it needs to be higher. So just moving on, there's more detail on that in the paper, but we asked the women what they thought about these tests, and basically there was ease of use was considered to be quite high, particularly for wet Dacron and dry flock swab. Only one woman finding it difficult. For the flock swab, none very difficult, and about 3%, 3 to 4% finding it quite difficult. Most of them found it very, 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 very acceptable. The same was true for urine in the sense, again, we had about 90% of them finding it either very easy or quite easy. 5 out of the 501, this is a double sample size, or 1% found urine difficult. Difficulties were seen at the quite difficult level for Quintip and Her swab, and the feeling was, from the women's comments, with these were considered a little bit too complicated. They didn't know if they were doing it correctly. So the simpler sort of devices seemed to be more favored by the women. Confidence of directly using it was also very, very clear in this level, and that is that if you looked at very confident, it was about 40-45% for wet Dacron and dry flock, whereas it drifted down to about 35% for the other two tests. So, and again, looking at particularly Her swab, 14% of the women were not confident that they'd actually taken a good sample. whereas the rates were down around. It was very happy for urine. 4.4% were not confident. Most of them very, very confident that they'd done it correctly. Even more positive in that sense than for the other vaginal samples. So women were much more confident in urine and basically also felt more, they liked it more. So just to get on to the conclusions, the positivity rates were lower than for clinically taken samples when we used the initially recommended cutoffs. But when we moved to a higher cutoff for HPV-16, the results were very, very similar. We had high cellularity for the flock swab and for urine, and her swab. A major problem with that was variation in the amount of cells that we collected, meaning that you had to make a cellularity adjustment to get reasonable answers. We felt that the Dacron and the flock swab were pretty similar overall and were better than Quintip and her swab, and a little better than for urine. But that went away when you adjusted for cellular volume if you were prepared to do that. This is a referral population with a high positivity, which is you normally use when you're trying to get readouts on sensitivity. We're now about to embark on a study of 2,000 women in which there are being screening samples. One of the other things is that this is, I think, the first study of size in which the screening sample and a clinical sample is being taken at the same time. So we should be able to directly compare those. We clearly need less stringent cutoffs for self-sampling. That makes, we can get up to about a 90-95% sensitivity for SIN2 if we do that. The other area which I haven't said here is we've actually also done methylation assays on all of these samples. And we find that one of the problems that's well known with HPV testing is that the specificity is low, although the sensitivity is outstanding. If you actually if you actually do a methylation triage assay, it performs as well as anything else and is much more effective in terms of reducing the low specificity for HPV tests. So thank you very much.